large percentage of severe COVID, despite being vaccinated and having all the therapy that we always give to those patients. The second reason, not all the COVID patients actually are the same. Some of the COVID patients have developed a persistent infection. And really, when we talk about immunocompromised, you really see here the immunocompromised are not all the same, because those are two studies that show that, for example, in this first study, the shedding or the probability to detect SARS-CoV-2 RNA in the nasopharyngeal is shorter in the non-immunocompromised host of people that have non-severe immunocompromised, but become very much longer in people that have severe hematologic malignancy, even compared to other type of immunocompromised diseases. And this is also true for people that have, that they distinguish also people with solid versus liquid malignancy. And you can see that people that have hematologic malignancies really have an infection that lasts much, much longer compared to other population. Those are data from Sloan Kettering across the street from us. But this is prolonged replication is important apart from the treatment. It's important because we know that this allows really a virus to evolve in the context of the same host without need to jump species. And so there is an accelerated intra-host evolution, and this is one of the first papers that reported this evolution intra-host in a patient with prolonged malignancy. And this accelerated intra-host evolution brings to the emergence of the new variant, and those are mutations that actually characterize the jump from, I think, from Delta to Omicron, and that was suggested to happen in an immunocompromised host. So starting from this background, we got interested in looking at what is the, sorry, 1 second, I need to close this from the screen. Okay, to look at what was the effect of the treatment of the viral dynamic during prolonged SARS-CoV-2 infection in individuals that had hematologic malignancy. And therefore, we collected a lot of nasopharyngeal swab from immunocompromised patients longitudinally, and we looked at 50 of those patients that had persistent infection, and persistent infection we consider all the longer than 28 days. And they were treated with remdesivir, Paxlovid, or monoclonal antibody. And we performed whole genome sequencing either by Illumina or PacBio, that is a new method that has a long read, so decrease the possibility of error. And only samples that had a high coverage, and we were sure that, that those were the real read were included in the analysis. And so this is the immunocompromised cohort, and this is work that we do with a long-time collaboration, Elodie Gedding, that now is NIH, and Kate Johnson. So those were all the individual patients, so they were across several waves, but the patients I'm going to talk today were all these from the Omicron era and in 2020, collecting 2022. And I just need to say what we focus on. We focus on the target gene of the therapeutics. And so just to, the genome of SARS-CoV-2 is extremely complex, and has some structural genes that are important for the structure of the virus itself, including, and also include the spike that we know we use for our vaccine. And then they have non-structural gene and accessory genes that are important for the host interaction. I will talk about this later. And the analysis for this 15 patient was focused on the sequence of the spike, that is the target for monoclonal antibody, the protease, that is the target of Paxlovid, the NSP5 protein, and the RNA-dependent RNA polymerase, that is the target for remdesivir. This is just the patients that we studied, and as you can see, those were heavily immunocompromised patients, a lot of dermatologic malignancies, and a lot of immunosuppressive therapies in the previous 6 months, including a lot of them had rituximab or steroids that have been shown to be associated with decreased response to viral infection. The PCR were positive from 28 days up to 190 days, and they were all treated with remdesivir plus or minus monoclonal or Paxlovid. So when we looked at the mutation in those genes, we went to look at what happened to the NSP5 and NSP12, target of remdesivir and Paxlovid. And what we noticed that a lot of patients actually had developed mutation. So 4 of 15 patients had NSP5 mutation, and 9 of 15 patients had mutation in NSP12. And we looked at mutation at the patients in which those mutations also became the prevalent, in a single patient, you have a mix of viruses. And so we looked at the patients where the frequency of those mutations were approximately 100%. And in those 3 patients that are in red, those were reaching consensus. And we tried, and also we had several samples, and we tried to recover the virus to see if we could get virus. One thing is having a mutation in a genome, but then if the virus was viable, we could recover the virus. And so one of those patients that I saw before, it was this patient that is a patient with multiple myeloma that just to whoever is not familiar with this type of patient, I just tell quickly the story. He had treatment with some monoclonal antibody that affected his B cell. And initially he presented to his doctor with mild disease. He was treated with Paxlovid, mild symptom improvement, went home until day 18. He had cough, dyspnea. He got to an ER close to home, and they said, hey, you have pneumonia, but they didn't retest him for COVID. And they gave antibiotics, gets discharged. 2 days later, of course, it doesn't get better, require oxygen and get admitted to our hospital, and is still positive for SARS-CoV-2. And then he gets remdesivir, gets discharged, and then he gets readmitted with pulmonary fibrosis, and he gets further another remdesivir, 2 additional remdesivir courses, and eventually, without not much effect on the symptoms, and eventually he worsened so much and he died 85 days post-infection. And here is just the treatments that he received, just to show the complex treatment that he had during his admissions of 80 days or 80 plus days positive for COVID. So, oh my God, it's so blurry. When we went to look at this NSP5 and all the other protein in time, what we noticed, first of all, that when we look at mutation, you can see that right before, when it got worse and died, the number of mutations were highly increased in his genome, and that also it developed. So here, those are the 2 alleles. This is the wild type. For example, this is the mutant. You can see that there were some resistance mutants erased during the course of the disease. And there were also mutants in other genes, but we focus on the one that bring to resistance to medication. So when we went to look, what we noticed, we tried to rescue the virus, and what we found is that actually there is this double mutant virus that emerges at 57 56 days after diagnosis, still reached consensus later in the course of the disease. And this mutant is a mutant in which he has resistance to both Paxlovid and remdesivir. So what we did, we actually tried to rescue the virus, and we were successful to rescue the virus at day 77 in the course of the disease, rescued in cell culture. And so we look if this virus would grow with the same, because sometimes when you have a virus that has mutation, this affects what is called the viral fitness. So the virus doesn't really replicate so well. So the question was, does this double mutant virus is able to replicate as well as a wild type, or it gets eventually lost in the subject? And when is in cell culture, actually this virus did grow very well, both in those viral cells and in the viral cells that express this co-receptor for SARS-CoV-2. So you can see that the mutant virus is in right red, actually in some time points even grows better. And then when we did plaque assay, the only difference was that the plaques of this virus were significantly smaller, but this was not really affecting the titer that the virus was reaching in the supernatant. So, okay, this is a virus that's this 2 resistant mutation, replicates well, but is really resistant to those 2 antiviral. So we did this experiment in which we wanted to see if it was really resistance to the antiviral, and we did, and we decided to check in cell culture, adding the antiviral either before infection or at the time of the infection or post-infection. So the cells were plated, then the antiviral was added, then were infected by either the wild type or the mutant, and then we were looking either of immunofluorescence or viral titer in the supernatant. And what we found is that, go away. And what we found is that if you look at both pre-treatment, simultaneous treatment, or post-treatment, this is with nirmatrelvir, that is the active antiviral component of Paxlovid, you can see that this virus is resistant because in the wild type for the same concentration, you see that you need a lower concentration. Here you get up to 3.3 micromolar, and here you can see still some red at 6 micromolar. Same with remdesivir. You can show that there is resistance, both if you do a pre-treatment, a simultaneous treatment, or a post-treatment with remdesivir. So this kind of confirmed that those viruses was at a decreased sensitivity to both Paxlovid and remdesivir. And here you can see the growth curve of the virus in the supernatant, and you see that in all the cases the curve is shifted to the right side, showing that that there is a decreased sensitivity to the antiviral. So, okay, this virus has decreased sensitivity in vitro. But our next question was, does it transmit in vivo? And to do, oh no, sorry. The next question was, what happened actually if we use those 2 drugs together? Is still resistant to both the drugs? And what it was interesting is showing that we saw that actually if you have pre-treatment, simultaneous treatment, and post-treatment, you see that actually when you use a simultaneous treatment at 1x at the IC50 concentration, you reestablish there is again sensitive to the drug in the combined if you combine the 2 drugs, you have you succeed in killing the virus, you reestablish sensitivity to the two drugs. And this has happened to both the pre-treatment, the simultaneous, or the post-treatment. And those are the curve in the supernatant. And again, you can see that there is an effective killing of the virus only in the case that when you do a combination with remdesivir plus nirmatrelvir, suggesting that maybe also in human using combination therapy approach can help in treating those viruses at decreased sensitivity that can raise in the immunocompromised host. After that, we wanted to know if this virus actually, first of all, replicates efficiently in the animal model and if it's transmitted in the animal model. And to do so, we infected mice, hamsters, either with SARS-CoV-2 mutated or with the wild type SARS-CoV-2. And then they were co-housed with animals that were not infected. And then there was necropsy done at the 14 days post-infection. And hamsters is a good model for transmission for SARS-CoV-2, but not a good model for, I mean, it's not killed by SARS-CoV-2. So that's why we do necropsy and titer. So none of it, as I was saying, this is not a lethal model. So in time, the animal either were infected with the wild type or with mutant virus, don't lose weight. And this is show the viral RNA post-inoculation, and you can see clearly that there is no difference, wild type with mutants, and this is those are the contact animals that are traced that are infected later. And this is those are data that show that actually the animal was they were infected, and those are the viral titer in the oropharyngeal swab, and the infected, and then in the contact. And this is for wild type and contact, and this is the same infected and the contact. This is for the wild type, and this is for the mutant virus. And then those are the titer, the viral titer in the respiratory tract, lung, trachea, turbinate. And we also checked antibody in the animals, and we found the same, more or less similar titers in the animals that were infected with the mutant virus or the wild type virus, and one animal that did not really infect well or didn't develop antibody in both groups, for each group. So then we look also at other part of the virus itself. So what happened to the spike? And also in the case of the spike, all the people that developed monoclonal antibody had a lot of mutation. And I want to focus on this patient, that is the patient in red, that had received sotrovimab. And one of those mutations, this 340D of sotrovimab, is a mutation that confers resistance to sotrovimab. And this is the patient. This is a patient that had myelodysplastic syndrome, had a bone marrow transplant. Unfortunately, he got infected very shortly after receiving the bone marrow transplant. For some reason, he was admitted to receive sotrovimab. It was not hypoxic, so they didn't think that he would receive, they didn't give him remdesivir. And then he was readmitted with severe disease, and then he had to receive the all treatment for COVID, remdesivir, dexamethasone, tocilizumab, high flow oxygen. But also this patient really got worse, received a second cycle of remdesivir, no improvement, and eventually he died. And again, also in this patient, we have a virus that it develops a double mutation. As a matter of fact, if you look at the spike, so this is the spike, and this is the mutation that is a well-characterized mutation that confer sotrovimab resistance. And so here, those are the treatment with remdesivir. Remdesivir was used for a longer period of time. And you can see that those mutation for the conferred remdesivir resistance, again, are on the backbone of a virus that already is a spike mutation, because the 100% of the, almost 100% of the isolate have those mutations. We were not able to recover this virus, but those data really strongly suggested this virus was a double mutant virus again. So just to summarize this part of my talk, so what really to go back and think about what this means in clinical practice, really make you think that that when the data that are shown in clinical trials don't apply to this population. First of all, this is a small number of patients, but there are a very high number of mutations that we found, including double mutation. And this is very different from the data that are reported in the approval remdesivir trial that shows that there are mutations that happen only one time point, and that the same similar number of mutations, both in the patients both in the patient and in their control. Also, there are maybe some mutations that might be more specific or more prone to emerge in people that have an immunocompromised host. For example, this is a mutation that also we described, and it was found a high frequency in this data set in the UK in 7.14% of people that had SARS-CoV-2 genome that were coming from immunocompromised hosts at the same mutation. And then, the other point is what is the best treatment for these patients? Do we really need to do any combination therapy? But combination therapy, which drug? Because right now there is no approved monoclonal for treatment. There is a drug-drug interaction with Paxlovid. Also, the course, you don't know when to start Paxlovid. You are supposed to administer in the first 5 days, but many of those patients present with a very mild course at the beginning. And we have really no tools to identify who will develop a prolonged infection with this disease. And then, is there a risk of transmission to others? Because when we have patients, this is not one of the patients, this is a recent patient, they have, for prolonged time, no symptoms with viral load, with CT value, I forgot this too, that they are in the 20s, they are indicating a high viral load for a prolonged period of time, and they are in the community. If they develop a mutation, are those mutations spread in the community? And do we need a special control measure? How frequent is the transmission to family member? And we're kind of trying to plan a study of the family member to see how frequent they get infected from one of those immunocompromised patients during the prolonged infection. And then another things that have been funded to do is, can we predict who developed a prolonged infection? Is there, because say an immunocompromised patient sometimes means not much, because those patients receive so many of immunomodulatory, other different therapy that is really hard to establish a priori who is the patient that we need to take more care of. And so when COVID hit, we had done a study in which we were profiling COVID patients to try to predict the severity of disease. And what we saw is that if you put all these samples on, so first of all, the patients can divide in a sort of pseudo time according with the disease severity, and they also can separate through their cell population, they separate in time. And so can we use a similar approach using this, this pseudo time to characterize a priori through to have a tool that through flow, through advanced flow, we can define which cell population can really predict, or defect on some cell population can predict the people that will develop prolonged infection. And I don't know if this is possible, but this is what we are trying to do. Then I want to switch gear to talk briefly about something interesting that we found as well. And one of the reasons why I started this study is because, coming from influenza, there are some form of virus that really interfere with viral replication. For example, if there is an antagonist protein, interferon antagonist protein called NS1, if you delete part of this NS1 protein, you can really interfere with another viral with the replication of a different virus, and you can also alter the course of the disease. And the same, or similarly, in influenza, there are some forms that are have deletion in a polymerase gene. They are defective in replication, but at the same time, when you add them to the full wild-type virus, again, they affect disease progression, the modified severe disease course. So one of the reasons why we had started this study was also looking at COVID, if there was a virus modification that allowed the virus to persist in the host. So we went to look at this 15 patients that we had, and we found that there were, we looked at the lesion and where they were located in the genome, and we looked at all the lesions were localized in this ORF7A and 8, and the ORF8 is an interesting ORF, is an accessory gene that is not essential for replication, but is very important for modulating the immune system. In particular, interfere with the interferon system and downregulate MHC class 1. And there is there are some reports that SARS-CoV-2 with deletion in ORF8 first of all are fit because they can cause an outbreak, and they apparently correlate with a milder disease course. And when we went looking specifically in our patients, we found that independently, 4 patients developed deletions in a very large deletion of ORF8 and 7 and 8. And what it was interesting is that the beginning and the end of the deletion actually are the same in these patients. Those deletions never actually acquired consensus, so it never became predominant, but it's still very interesting independently. Those areas are affected in the same, those are affected in 4 different patients at the same time. And we don't know how this in fact affect viral replication, if they contribute to persistence. They might also be specific site of recombination. We don't know. We are trying to actually rescue this. So right now we don't know what's the significance of this, and we are trying to rescue those viruses or engineer and see what their effect in vitro. And then we also analyze the entire cohort and look at new samples to see if this is also common in different lineages. And then the last study, the last point that kind of I really wanted to make and to talk about is that has been reported since the beginning of the disease that COVID also is present in different clinical specimens. It's not only in the respiratory tract, but also in the GI tract. This was reported at the beginning of the disease, but it was also thought that that is coming from the mouth, but then there is another study. It was like swallowed, but then studies have shown that the virus is present, can infect the GI tract, and the shedding is actually much longer in the GI tract, although this was never recovered. So we are also doing some study to see if there is infectious virus in the stool, and if this can be recovered, and if it evolves differently from the respiratory tract. Also the other thing, this has happened in COVID, but also we know that immunocompromised host has a lot of prolonged shedding also for other viruses, including influenza. And we know definitely that influenza is the leading form, and we are looking at the evolution of influenza in the immunocompromised host that has never looked before, because I think the variant idea really came with COVID, and nobody thought about evolution of flu in the immunocompromised host as a way for the virus to evolve. So in conclusion, and in summary, so what we did is really look starting from samples from patients, and this is really a circle in which we start from patient sample and patient tissue, and looked in vitro in the animal model, and then we are thinking to develop strategies to help treating those patients again. And with this, despite doesn't look, takes really a village, and I am here for any questions. I'm sorry for the technical mishap.
Just let them know online. They can chat any questions they may have.
I saw some stuff online.
Oh, that's fine.
Oh, the PowerPoint, yes.
Sorry.
Of course. It's all locked.
Question, Ralph. If you could repeat it then for people. I'm just wondering, with different vaccines and the most recent vaccine that has been available in the past month or two, how do you see these impacting? Is there impact on resistance with the vaccines or transmission, or does it make it any more difficult to study?
I don't think that the vaccine will affect the host per se, because many of those don't respond to vaccine. Actually, we wanted to look at vaccine responses. For sure, will increase the spike evolution. I think that the vaccine will affect the evolution of the spike in the population, and maybe accelerate it, not necessarily in the immunocompromised population. I think that the reason why we don't see a lot of this mutant in the general population is because those mutations are not on the surface protein. I mean, apart from the sotrovimab and those, the virus evolved quickly, but the mutation to Paxlovid or remdesivir are not in the population, because maybe the relative, if they get vaccinated, they get rid of the virus. But this would be, actually I was wondering if this is going to be a problem in the children that very often are not vaccinated, or if they live with another more immunocompromised host. And I don't know, because nobody has studied the children per se, how much the virus evolved in children. Also that, and I remember my kids being positive forever, and the doctor said, well, don't check, and send them to school. It was a great approach.
There's a question in the chat.
Question in the chat. How do I see that? Do you advocate combination therapy for certain patients? Conceptually, the idea of using a PI with a polymerase inhibitor makes a lot of sense. We have done this occasionally, seem to work. We have been a fan of early adoption of that approach rather than sequential monotherapy. Yes, definitely. I always like the combination therapy, is that sometimes it doesn't go in the guideline. I was sharing with someone that I had tried, I wanted to, for flu happened the same. And so when Baloxavir went on the market, I designed a combination study that I was hoping to do. But COVID arrived and flu disappeared. Also, given the rapid mutation in spike, and now with early universal SARS-CoV-2 infection, pooled immunoglobulin has high level of SARS-CoV-2 and S and NC antibody. The problem with the monoclonal antibody, I think, is always the same, that we don't exactly know the titer, and if you put a low titer in the immunocompromised host, often they develop resistance. And so we kind of increase the resistance in the population, I think. I mean, of course, it's all anecdotal and nobody has done the full study, but seeing the rapidity in which spike resistant were present in those patients, including patients that never received monoclonal. Actually, we are going back to see if patients that after receiving IVIG, they have an increased rate of mutation, but we don't know that yet.
So, and I think he asked, which patients would you recommend combination therapy? The sickest, or?
Well, I think the immunocompromised with hematologic malignancies are the ones that have really
For combination.
Are the one that develop antibody more than the solid organ. There are many papers that have combination, but all are done kind of retrospective data. They are not prospective. I think that also it's really difficult to decide, because sometimes they're fine and they ignore it, and then they come back and they're very sick, and then they like, okay, now this drug is not approved for this. I mean, Paxlovid is more than 5 days. Should we give Paxlovid or not anymore? And so that's nobody knows if it's okay to give it later or not. But the other thing I noticed, that many oncologists tend not to treat or not to worry about. And I also saw a lot of patients that develop pulmonary fibrosis. I don't know if you saw this here too. And I feel like we treat hepatitis C because of liver fibrosis. What's different from a prolonged infection with COVID? Why don't we think that this is actually can give pulmonary fibrosis? Yeah.
So in your double mutants, you've got a single population of double mutants that you've recovered from patients. I'm just curious, in your in vitro studies, what's the mechanism by which you restore activity of the two drugs together?
Can you just repeat the question?
Yeah, so the question is, what's the mechanism by which you restore the sensitivity? I think it's because the virus, you decrease the replication and then from each of them, and so in a way you restore it because you attack the virus to different targets, but we didn't specifically study, but I think that's the way should be.
I mean, do you think, based on those data, that the two drugs together would have activity against the double mutants in vivo? Or do you think that it's just a kind of weak activity? I'm just curious. Because it kind of gets to the idea of, can you use double drug therapy later on once these patients have already established double mutations?
Try to repeat.
So the question is, do you think that the same activity would be present if we use double therapy in a patient with a mutant virus later on in vivo? I think that all depends on the type of mutation, the fitness of the virus. I mean, this virus is keep fitness, but is not 100% resistant. So I feel like if you do it before is better than doing after. So if you prevent the resistance, it would be better than using later, because I mean, depends on how much of the activity of the drug is taken away by the resistant virus. And so in this case, there was a decrease, but it was like 2-fold decrease or 3-fold decrease. But maybe if it's 20-fold decrease, even if you use double therapy, you don't really get an effect. Yeah, I don't know.
Any other questions? See if there's any in the chat here.
Yeah, I think I don't see. Oh, one new message.
I think he just said he can't hear the question.
Oh, I
That's
can't
why
hear
I
the
was-
question online.
that's why I
Yeah,
was bothering
sorry.
you. Thank you, appreciate it.